Good evening, everyone. Today, topic of discussion is approach to polyarthralgia. My moderator is Dr. Sarma, sir. Patient particulars. Name of the patient is J. Padmavati, of age 48 years, female, belongs to Orissa, and she is a housewife. She presented to general medicine OPD with chief complaints of early morning stiffness and pain in small joints of both upper limbs since 2 months.
Wait a minute. Here, one important point is female is essential. Early morning stiffness is essential. Small joints is essential. Why? There are certain diseases of the joints which occur exclusively or more in females. Likewise, what is early morning stiffness?
Inflammatory.
No, just how do you elicit early morning stiffness? How do you ask the patient?
Stiffening of the joints are to do any activity, the patient feels.
See, for example, I get up in the morning and I have a stiffness of my hands like this, and I'm not able to use them to hold anything for 5 minutes. Is it early morning stiffness?
No, sir.
How long?
For 30 minutes, sir, at least 30 minutes.
Minimum of half an hour. They will not be able to use particularly the small joint means they will not be able to hold anything, make a tight grip like that. And this is very common in inflammatory arthritis and in autoimmune, particularly the rheumatoid arthritis. Early morning stiffness is a very important feature. Osteoarthritis, the stiffness is more after use. Later in the day, the joints become stiff and painful. Whereas in rheumatoid arthritis and inflammatory arthritis, it is early morning stiffness that is very important. Okay.
Yes, sir.
Small joints means there are certain diseases which occur. Small joints, peripheral joints, axial joints. Axial joints and appendicular joints. Appendicular joints means related to the hands and toes and things like that. Axial joint means the spine and the SI joints, and these are the axial joints. Ankylosing spondylitis is a disease of the axial spine, and the rheumatoid arthritis is a disease of the appendicular spine. Osteoarthritis is a disease of the large joint, usually, and not small joints. Okay, so this is very important. And rheumatoid arthritis, more in females, SLE, more in females, hypothyroidism, more in females. That is why gender, early morning stiffness, there's another important thing called the joint count, joint tenderness, small joints, appendicular versus axial, small versus large are important points in the history.
History of pain in small joints of both the hands, which is insidious in onset, gradually progressive from past 2 months, which is aggravated with rest, relieved with activity after an hour. And it is also associated with early morning stiffness and swelling of distal interphalangeal joints of second and third fingers of right limb. History of pain in bilateral knee joints since 1 year, which is also insidious in onset, gradually progressive from past 1 year, which is aggravated with rest, relieved with medication and activity.
This is important. Suppose when she is resting, it is aggravated by rest and relieved by medication or activity. Osteoarthritis is the reverse, increased by activity and relieved by rest. Whereas the rheumatoid arthritis is aggravated more at rest, and as the day progresses, they become less stiff. And then another thing is it acute arthritis or traumatic joint pain or acute in onset. The inflammatory arthritis, acute septic arthritis, gonococcal arthritis, other viral arthritis or acute in onset, insidious onset. We are looking at something like the rheumatoid arthritis, the SLE or other diseases, crystal arthritis. Another thing is waxing and waning. It will be the stiffness will be there, the pain will be there for a few days, relieved, and again comes. That is usually gout or crystal arthritis. So in between periods of normal function, coupled with excess, the pain on either side is what is called the crystal arthritis. Okay. Now, let us go to the next slide.
Actually, the patient belongs to Orissa, sir. So not much complaints are understood. So after they have told that after a day his son will be coming, so we haven't asked. Past history, we got to know that she's a known case of hypothyroid and was on 50 mcg, but she's non-compliant to drug. Not a known case of diabetes, hypertension, or cardiovascular disease, or CVA, surgery, or any blood transfusion.
This is a problem. My friend who studied with me MD medicine, he lost his examination because the patient is from Orissa, not able to communicate well. History was not properly elicited. The informant also, there is one informant they have given, he is also equally not knowledgeable about Telugu or any other language. With the result, he missed a very beautiful point in the history and he had to lose the exam. Very pitiable, isn't it? So this happens. Why that is important is, even when in a clinical practice, you are not able to elicit the history, you have to pool your all other resources and make a proper diagnosis. That is the idea here. In not getting him through, the idea is that, see, a person who is blind is there. One important indriya is compromised, but still he should be able to lead a relatively normal life. That is exactly here. When we don't have a proper history, then we are handicapped. This you have to remember in this one. Okay.
After a day of admission on arrival of his son, further questioning regarding the disease activity, he revealed she has history of painful discoloration of hand on exposure to cold, that is during winters, which reverts back on rewarming. History of small ulcers at the tips of the fingers after such episodes. History of darkening and thickening of the skin from past 5 years. History of difficulty in swallowing on and off for both solids and liquids from past 2 years. History of decreased physical activity due to shortness of breath on exertion over past 2 years.
The case is taken away from the joint pain to somewhere else because it looks like a multi-system involvement. You have the dysphagia, you have the skin discoloration, you have the shortness of breath, you have the Raynaud's phenomena, all put you under a different category of autoimmune disease, dermatomyositis or scleroderma, or a combination of both is a possibility from the history. I'm just guessing from the history. Here there are positive points there are Raynaud's phenomena, ulcers also are there, skin pigmentation, dysphagia particularly, both solids and liquids progress over 2 years, and physical activity due to shortness of breath is limited. That again shows, dermatomyositis and scleroderma are good possible diagnosis, apart from the other diagnosis. We'll see how things go. Go ahead.
History of bloating, burning type of chest pain after ingestion of food. History of difficulty in getting up from squatting position. Difficulty in combing hair and hooking and unhooking blouse. No history of difficulty in walking. Slippage of slippers, are able to roll over the bed. No history of palpitation, syncopal attacks, orthopnea or PND. No history of decreased urine output, facial puffiness, swelling of limbs. No history of dry cough, decreased sweating, lacrimation or salivation. No history of abdominal pain or yellowish discoloration of eyes.
In a way, you are excluding some paralytic illness like slippage of slippers, difficulty in walking, rolling over bed. Means it is not a neuroparalytic disease. That is one you want to say. Second thing is, you don't have any cardiac disease underlying palpitation, syncope, and then the orthopnea and PND has been excluded. Renal disease is excluded as a cause, facial puffiness, swelling of the limbs, decrease is not there. And then decrease in sweating, lacrimation, salivation is, the form of rheumatoid arthritis where Sjogren syndrome or dryness of the eyes and all these things can occur. That also in a way you are excluding. When you are making some specific mention, you should keep in mind what you are trying to exclude. Jaundice also excluding. Hepatological conditions also are excluded. Okay.
General examination. Patient is moderately built but poorly nourished. Coming to vital data. Pulse rate 86 beats per minute, which is regular in rhythm, normal in volume, normal character with no radio-radial delay and no radio-femoral delay. BP 160 by 90 mmHg in left arm supine position for 3 consecutive readings. Respiratory rate 18 per minute, which is thoracoabdominal type. Saturation is 98% with room air. Temperature is 97.6 Fahrenheit.
Except that a poorly nourished individual, there is nothing contributory from this.
Yes, sir.
Okay.
On examination, pallor present, stellate scars which are present on tips of our fingers, microstomia, no pinched and beak-like, thin skin which is elicited by skin pinch test, finger mouth test, that is restricted mouth opening by placing the 3 fingers. She couldn't; these 3 fingers couldn't be completely gone, so there's a restriction of mouth opening, decreased wrinkling on forehead, sir.
All these are things pointing towards the scleroderma.
Yes, sir.
Okay.
Systemic examination, previous S1, S2 are present with no murmurs. Respiratory, air entry present with the normal vesicular breath sounds. For abdomen, it's soft, no organomegaly. CNS, higher mental functions are good with no focal neurological deficit. Investigation, sir. Initially, we thought this is a case of rheumatoid arthritis, sir, as before all the history heard. So initially, we sent the routines like complete blood picture, LFT, RFT, complete urine examination, RBS, viral markers, chest X-ray, ESR and CRP quantification. ESR and CRP were elevated. RA factor, uric acid, and anti-CCP, sir, initially. And later on, coming to the history, we have sent ANA profile, ECG, echo, HRCT screening, sir.
Who are the RA factor and serum uric acid and anti-CCP?
RA factor was negative, sir. Serum uric acid was also in normal limits, sir.
Anti-CCP?
Anti-CCP is also in normal, sir.
ANA report not received as it.
ANA was awaited. Anti-CCP is submitted, sir. It's normal, sir. ANA is awaited.
Awaited. HRCT screening also you did, and 2D echo also you did, ECG.
Yes,
does ECG show any abnormality?
It's a normal ECG, sir.
Okay. Yeah, this is the results you are showing. ESR 130. Anemia is there. What type of anemia? 3.4 multiplied by 3 is 9.2 less, and that multiplied by 3 is 27. So there's some amount of microcytic anemia is there. Mean cell volume is 79. MCH also is decreased microcytic hypochromic anemia. Okay, platelets are now. This is CRP is very much elevated, no doubt. Thyroid, TSH is very heavy. Hypothyroid, see, classical hypothyroid picture. You can see here because 28 TSH and T4 and T3 are not yet suppressed. Okay. Now renal function test, nothing wonderful. Looks more or less okay for me. Anything you identified here now?
Nothing.
Then anti-CCP within normal limits, 48. This is the X-ray, is it? This is what you are telling over phone, isn't it?
Yes, sir.
Yeah.
And the next one, sir,
this X-ray doesn't show erosion of the articular surfaces or widening of the joint spaces or deformities or any displacements, joint dislocations. What we expect in rheumatoid arthritis is very much missing in this X-ray. This is not a classical rheumatoid arthritis X-ray. Yeah. This is what is your doubt here?
Yes, sir.
It quite looks very normal to me. I don't think there is anything very specific in the enlarged view. Okay. Go ahead.
2D echo is a normal study, sir. But on HRCT screening, it was showing ill-defined hazy ground glass opacities in apical and anterior segments of right upper lobe, sir. On taking the dermat referral, we have taken, they have done nail fold dermoscopy, sir, showing hairpin shaped vessels with and few hair capillary dropouts, sir.
Okay. In your profile, I waited. Supposing I do a 2D echo, if it is scleroderma, what sort of abnormality I expect?
We'll be expecting pulmonary hypertension, sir. Normal LV function with
Pericarditis maybe. Evidence
yes.
of pericarditis, effusion or constrictive pericarditis. Maybe there, pulmonary hypertension is a possibility because lung expansion is restricted. That is, they are missing. The ill-defined hazy ground glass opacities. Can we see the picture if you have?
I have video, sir.
Oh, you have a video. Did you post it here or you want to play from there? Otherwise, you send it to me if it is a short video. Put it in the WhatsApp. I will try to play it. This is that.
I'll send you, sir.
This is the nail fold. This one is it.
Yes, sir.
Approach to polyarthritis for primary care physicians. Can you see the article?
Yes, sir.
Only 14 people are there. So many PGs are supposed to be there. Put a message, they cannot attend. So complaints of joint pain are. Hello? Reiki.
Yes, sir. Hello.
Can you speak again?
Hello, sir.
Tell me, why only 14 are there? I asked.
I will keep a message, sir.
Yeah,
I've already kept a message.
Yeah. But again, you put a message, let us see. Okay. Now, most important thing is polyarticular joint pain is a common complaint that is encountered, no doubt about it. Differential diagnosis is not that easy and extensive diagnostic procedures are required. Comprehensive history and physical examination are very important. Okay. So distinguishing whether arthritis is an inflammatory can narrow down to a few differential diagnosis. Inflammatory conditions often cause synovitis and there will be warmth and there will be swelling as well as prolonged morning stiffness. So there will be synovitis is there means you feel the warmth on the joint, you feel the warmth, there will be swelling, there will be effusion, there will be early morning stiffness, and that is inflammatory. These conditions also cause general constitutional symptoms like fever, rash, arthralgia, myalgia complex. Physical examination, we start the arthritis, it's a non-inflammatory condition, often reveal osteophyte and a crepitus while you are moving the joint as opposed to inflammatory arthritis, which will demonstrate findings of synovitis. There will be fluctuation, there will be pain and tenderness, there will be fluid collection. So when there is fluid collection, you have an option of drawing the fluid for testing and laboratory workup there. So imaging is also important. So now most important thing is patient's history, although laboratory studies might be conclusive, it is important always to have a very thorough physical examination and a history. So vast differential for polyarticular pain is greatly narrowed using the history. One important thing as clinicians you must know is it an emergency condition? That we have to exclude. For example, somebody has got a history of trauma and joint pain, obviously it is an emergency. Okay, so during initial evaluation, patient must first exclude any life-threatening conditions which may present as arthritis. What are the life-threatening conditions? A warm, swollen joint should raise the suspicion of infection, and a diagnosis of gout also is possible. Constitutional symptoms like fever, weight change, fatigue may indicate systemic rheumatic disease. Sepsis is very important. Joint sepsis can lead to septicemia, and then you should always exclude neurodegenerative neuromuscular disorder, radiculopathy, neurogenic pain should be excluded. Okay. Now, joint involvement, you have to have it's a very nice algorithm. I would like to present you that algorithm given in this paper, apart from the one which you have from the Harrison. Characterizing the joint symptoms is in a patient is experiencing is an important aspect of diagnostic approach. What we have to do? Usually joint swelling will not be seen in non-arthritic conditions. Arthritis is defined as the joint inflammation alongside the joint pain. That means arthralgia, arthritis. Arthralgia may be from a general cause. Arthritis is usually there is a specific involvement of the joint. In contrast to arthralgia, which lacks inflammatory component, it is important to make the distinction: is it arthralgia or arthritis? How do I know? Surrounding edema, warmth, tenderness, swelling. These are the Keller, Rover, Dollar, you have what you know in pathology. Those things will be present here. The quality of the pain, the patient reports also will guide. True articular pain will be expected to improve with rest of the joint and worsen with movement or stress. That is generally we see that. So now, how do you go about general approach? Polyarthralgia, not arthritis. Means what? Polyarthralgia, history and physical examination. Evidence of synovitis, then we are looking at polyarthritis. When there is no evidence of synovitis, tenderness of joint, there is no evidence of warmth, there is no swelling, there is no evidence of fluid collection, there is no fever, then you are out of synovitis. Then the joints may be tender or not tender. If it's a tender joint, the tender points are there here and there without there being evidence of synovitis. You are dealing with fibromyalgia, bursitis, and tendinitis also can be tender points. Consider viral arthralgia, osteoarthritis, hypothyroidism, neuropathic diseases, Charcot's joints and others, bone disease, soft tissue diseases, and depressive illnesses. Patients with depressive illnesses, they have somatize the disorder, saying joint pains, muscle pains, like that. Okay, in those cases, consider doing LFT, hepatitis serology, X-ray of the X-rays, thyroid studies, calcium, serum albumin, and alkaline phosphatase. So look at these differential diagnostic features. Symptoms lasting more than 6 weeks. If you have that, then you have synovitis present, or the symptoms more than 6 weeks or less than 6 weeks. If they are less than 6 weeks, early rheumatic condition or viral arthritis. Do CBC, LFT, hepatitis serology, and parvovirus. Suppose there is duration is more than 6 weeks, then you have done that CBC, ESR, rheumatoid factor, ANA, renal function, uric acid, joint aspiration. Because there is synovitis, you have a chance to aspirate the fluid. So this is one algorithm which you can use. We will go and see the other algorithm also. Now, look at this very nice way of presentation. Systemic rheumatic conditions. What are the systemic conditions which present as arthritis? First and foremost, rheumatoid arthritis, systemic lupus erythematosus, scleroderma, polymyalgia, polymyositis, Still's disease, Sjogren's, sarcoidosis. This is the differential diagnosis. There is a systemic involvement and there is also a joint involvement, as we see in this case. Here, the diagnosis of rheumatoid arthritis is excluded by your anti-CCP. Rheumatoid arthritis are negative, crest arthritis also is excluded, but you have scleroderma as a possible diagnosis. Supposing it is infectious, then is it bacterial, is it viral, is it gonococcal or non-gonococcal? Non-gonococcal arthritis, gonococcal arthritis is a possibility. What is Lyme's disease?
Yes, sir. Yes, sir. Tick-borne infection, Borrelia.
It is a vector-borne disease. Most common vector-borne disease of the United States. Borrelia, bacterium Borrelia, Burgdorferi. It is the cause of Lyme's disease, and Borrelia mayonnaise can cause that. Okay. Now, apart from that, it's not very common in this part. Tubercular infection of the joint. Tubercular arthritis is a possibility. We have seen quite a number of tubercular arthritis. Usually, spine also may be involved, part disease may be there when you have a tubercular arthritis. Okay. Now, you have crystal-induced arthritis. Now, differential diagnosis, is it systemic rheumatic condition causing arthritis? Second one is it infection that is causing arthritis? Is it bacterial? Is it viral? If bacterial, gonococcal, non-gonococcal. And then viral arthritis, Lyme's disease and tuberculosis. Crystal-induced, gout and pseudogout, and spondyloarthropathy. These are diseases which involve the spine as well as the joint. Spondyloarthropathy, ankylosing spondylitis. Generally, the axial skeleton is spared. The appendicular skeleton is spared. It is the axial skeleton that is involved. Rheumatoid arthritis, the axial skeleton is spared except the first joint, that is the atlant-occipital joint, may be involved and can produce subluxation and rheumatoid arthritis. Rest of the spine and rheumatoid arthritis is absolutely not. Whereas ankylosing spondylitis, the starting point is sacroiliac joint and goes up. Okay, psoriatic arthritis. There will be skin evidence plus arthritis. Inflammatory bowel disease and arthritis. You have IBD like, Crohn's disease or any condition, inflammatory bowel disease and arthritis. Reactive arthritis, post, UTI reactive arthritis. Juvenile idiopathic arthritis. These will have a component of the spine and a component of the joint. Then systemic vasculitis causing polyarthritis, nodosa, granulomatosis, Rachakonda infertura, etc. Endocrine diseases producing arthritis. Hyperthyroidism. In this case, hypothyroidism is there, though the T3 and T4 are not that much depressed. And then you have to first elicit whether she is taking any antithyroid drugs or any drugs which could have resulted in TSH elevation. Other osteoarthritis, fibromyalgia, amyloidosis, and malignant deposit in the joint. So this is a beautiful way of looking at. So fasting is systemic rheumatoid condition, infective condition, crystal-induced, spondyloarthropathy, systemic vasculitis, endocrine disorders, and others. Okay. So next thing is, depending on joint symptoms, you can also see. For example, intermittent, migratory, additive. 3 types. Intermittent means episodes of polyarthritis symptoms with complete resolution between the attacks. This occurs in gout, pseudogout, and reactive arthritis. Intermittent arthritis, patient has symptoms, episodes of polyarthritis, normal joint health, again another attack of arthritis. Migratory, joint symptoms resolve and then reappear in another joint. This is called migratory. Started here, migrated to the shoulder, migrated to the joint, knee joint, like that. This is a feature of Lyme's disease and gonococcal arthritis. Intermittent arthritis, gout, pseudogout, reactive arthritis. Migratory, Lyme's disease, gonococcal arthritis. Additive means the existing joint is painful, another joint is added. Symptoms of the joint persist, additional further joint involvement over a period of time. This is a classical feature of rheumatoid arthritis, osteoarthritis, and systemic lupus. In osteoarthritis, larger joints and rheumatoid arthritis, normal involvement is usually the metacarpophalangeal joint. This is the metacarpophalangeal joint or the proximal interphalangeal joint. Tips are spared. Tip means terminal interphalangeal. This is spared. Terminal interphalangeal joint is spared. This is the proximal interphalangeal joint. That is the moment proximal interphalangeal joint. Metacarpophalangeal joint. Particularly metacarpophalangeal joint of the thumb is very much involved, and the carpometacarpal joint of the thumb also may be affected in rheumatoid arthritis. There you require to know the joint count and joint tenderness, both. How many joints are there? 1, 2 to 5. It is 10 and 10, 20, this one and this one, this one and this one, and then the knee and ankle. 28 is the joint count total. So out of the 28, how many are involved? I think we have looked at rheumatoid arthritis. In that we have. So another important feature of a patient of rheumatoid arthritis is, are there any extra-articular manifestations? This will narrow down the diagnosis to a different. Many rheumatological causes of polyarthritis will also present constitutional and systemic signs. fever, weight loss, fatigue may be seen, multi-system involvement in rheumatoid arthritis, SLE may be rash, adenopathy, mucosal ulcer, Raynaud's, xerostomia, keratoconjunctivitis, the psoriasis arthritis, of course, setting a history of psoriasis and classical nail findings such as hyperkeratosis and pitting, and then the tracing sign will be positive, and then the spondyloarthropathies may have a feature of involvement and of the spine as well as the joints with mucosal lesions. Inflammation associated with RA stretches way beyond the boundaries of the joint. Subcutaneous and pulmonary nodules may develop. Vasculitis and peripheral neuropathy may be there. Pericarditis may be associated with effusions. Particularly, I told you, in rheumatoid arthritis, scleroderma, we can have pericarditis and then effusion. Similarly, RA, gout can result in cutaneous nodules, which are called the tophi. So, always look for systemic signs, skin signs, bowel signs, lung signs, pericarditis, and then involvement of the multi-system. In addition to synovitis, with rheumatoid arthritis, spondyloarthropathies also, they have enthesitis. These conditions also present with spinal inflammation and dactylitis, that is sausage digits it is called. Dactylitis is the very painful fingers will be there. Okay. Now, in the physical examination, important to see the joint integrity, whether the joint structure is disturbed, whether the functional integrity is preserved or anatomical integrity is preserved. And of course, you do the lab studies. Here the labs are ESR, C-reactive protein, antinuclear antibody, and you have rheumatoid factor, anti-CCP, serum uric acid, synovial fluid examination, provided you have inflammation and fluid collection. So if it is 0 to 200 cells are there, WBC, and less than 25% are polymononuclear leukocytes, that is normal joint fluid. Less than 2000 but more than 200, it is non-inflammatory collection, and PMN are less than 25, usually osteoarthritis. Inflammatory joints, 2000 to 50,000 WBC count will be there, more than 75 will be PMN. That the reason will be rheumatoid arthritis, psoriatic arthritis, or gout. If it is septic joint, there will be more than 50,000 WBC count, and 90% or more will be polymorph. This is septic arthritis or gout or reactive arthritis. So we have differentiated based on 2 or 3. Is it a systemic disease? Is it infection? Is it crystal? Is it spondyloarthropathy? Is it vasculitis? Is it endocrine? Is it other? That is one way of differentiating. The other way is it intermittent, migratory, or additive? These will also help you in the future. Are there any extra-articular manifestations? Then we went into investigation and also looked at joint aspirate. So these are the various ways of deciphering the problem there. Now you see, polyarthralgia with effusion and inflammation. Okay, joint aspiration is done, bloody fluid, mostly it is a coagulopathy, or patient is receiving anticoagulants from outside. Coagulopathy due to external administration of anticoagulants, or there is a coagulation disorder, pseudogout, or a tumor, or trauma. Then in that case, you do PTINR, look at the platelets very immediately to exclude coagulopathy. Supposing there is bone marrow elements are present, that means joint aspiration has got bone marrow, means what? Normally bone marrow should not be there in the joint. Means there is an articular fracture, intra-articular fracture, bone marrow seeped into the joint fluid. And you can see the myelocytes, all the myeloid elements, erythroid elements of the bone marrow in the joint fluid. It suggests there is an invisible or minor intra-articular fracture. Suppose there is more than 2000 WBC, and most of them are polymorphonuclear leukocytes. No, they are not like that. Osteoarthritis, soft tissue injury, viral. Yeah, they are like that. That means more than 2000 WBC and more than 75% are PMN. Are there associated crystals? Yeah, gout and pseudogout. Is a culture positive? Infective arthritis. Sterile fluid? Probably viral or rheumatoid arthritis, SLE, Lyme's disease, sarcoid, spondyloarthritis. Okay, this is how you differentiate based on the bloody fluid, bone marrow elements, WBC, PMN. WBC and PMNs are low, osteoarthritis, soft tissue injury, and then viral infection. There are crystals, it is gout. It is birefringent, green, the birefringent crystals of gout can be seen. And typical history will be there. Alcoholism will be a background there. And then the culture positive infection, arthritis, gonococcal, and then sterile fluid you see in viral diseases, SLE, Lyme's disease, sarcoid. And what I have to do? I have to check CBC, ESR, rheumatoid factor, consider LFT, HLA-B27 for spondyloarthritis. HLA-B27, 90% of cases of ankylosing spondylitis are known to have this marker HLA-B27. ANA clinches the diagnosis of scleroderma, polymyositis, dermatocyte, myositis, and Lyme serology also can be done. So this is how this paper is written. I will share this article. In addition, I have one more chart to show, which I will share.
Yes, sir.
Yeah, this is the first level algorithm. What we do is, we will do the complete history and physical examination, and then polyarthralgia, you do complete history and physical. Synovitis is present, yes. Synovitis is absent. Synovitis is present, is it more than 6 weeks? Yes, it is rheumatoid. Rheumatic disease to CBC, ESR, RF, anti-CCP, ANA, creatinine, urine analysis, joint restoration. It is less than 6 weeks. Usually viral arthritis, early systemic rheumatic disease, careful follow-up, check the blood count, check the liver function test, and then consider hepatitis B serology as the joints are, the synovitis not there. There are tender points, yes. Fibromyalgia, patient will say, yeah, this is the point, it's most tender. In fibromyalgia, very typical, patient will come with one finger, this one, and multiple sites of bursitis or tendinitis also may be there. Along the tendons, there is fluid collection and tenderness, tender points may be there. And bursitis, particularly wherever there are the typical superficial bursae, and they can have bursitis, and then you have peri-ankle region, and then peri-wrist region, and here the bursitis is very common. And then if the tender points are not there, viral arthralgia, osteoarthritis, soft tissue abnormalities, hypothyroidism, neuropathic joint, metabolic bone disease like Paget's and others, depression. And that's very important. Consider liver function test, hepatitis B and C serology, radiographs, TSA, calcium, albumin, alkaline phosphatase. This is what they have also shown more or less in the first algorithm. Then there's the second one is, full history and physical examination. Is there any history of trauma? Immediately investigate and treat for trauma. There could be a rupture of the tendon, there could be a ligament tear, there could be an actual injury of the joint surface, there could be an intra-articular fracture. Depending on this one, you can treat. If it is negative, no history of trauma, there is suspicion of infection or crystal, yes, perform arthrocentesis. It means there is already fluid, and that fluid can be aspirated, and diagnosis can be confirmed and treated. Suppose I aspirated, it is non-diagnostic. It looked like a sort of non-inflammatory condition or a normal joint fluid, just as what we have seen, non-diagnostic. Are there any other features in the clinical presentation, laboratory investigation, and imaging other than the suspicion of, other than the trauma is negative, and then there is suspicion of infection or crystals, but that is also not there, but there are other features in the joint presentation or in the lab or the imaging. Yes, is there a specific diagnosis or group differential diagnosis according to the number of joints? It's very useful. Single joint involvement, multiple joint involvement. Single joint involvement, you consider Axial, peripheral, spondyloarthritis. Axial joint or peripheral joint. You have to understand. Axial or appendicular. Axial, we are dealing with ankylosing spondylitis. Peripheral, we are dealing with rheumatoid arthritis and osteoarthritis, crystal-related arthritis, and then the infectious arthritis, and then rheumatoid arthritis. Other conditions, avascular necrosis, connective tissue disease, sarcoidosis, malignancy, viral, Lyme's disease, migratory arthritis, and then the endocrinological features, polymyalgia rheumatica, adult onset, Still's disease, vasculitis, usually single joint. More than one joint, rheumatoid arthritis, usually polyarthritis, connective tissue disorders, axial and peripheral spinal arthropathy, spondyloarthropathy, crystal induced arthritis, osteoarthritis. Other conditions again same like that, avascular necrosis, sarcoidosis, malignancy, infections, viral, Lyme's, they can present with multiple joints also. And more or less, one or more is very important. Then, once you make a specific diagnosis, treat it. UPI, undiagnosed polyarthritis. Undiagnosed polyinflammatory arthritis. So, consider revisiting the diagnosis and obtaining additional investigation periodically, or if new features or worsening of the clinical condition, then you do and go back to the whole routine. If the joint pain subsides, undiagnosed polyarthritis with analgesic, self-limited, then you stop the evaluation. So these are the two algorithms I have. Now you have one algorithm. And what is that algorithm? Let us see our presentation. That is from Harrison. Visible?
Yes, sir.
Yeah, we go to the algorithm. So you have cut part of that algorithm. It is there. Algorithm for musculoskeletal complaints. Musculoskeletal complaints. Initial rheumatic history and physical exam determine is it articular, is it acute, is it chronic, inflammatory, inflammation present, how many, which joints are involved. Is it acute, focal or monoarticular? Yes. Consider red flag signs, gout, septic arthritis, fracture, vascular ischemia, carpal tunnel. Why red flags? These are emergencies which should be treated. Particularly carpal tunnel, you have to release this one fracture. You have to attend ischemic vascular condition. You have to improve the ischemia. Gout, you have to specific treatment you have to make. Septic arthritis can lead to septicemia. These are the red flags. Then, no, it is acute and focal. Monoarticular. No, it is not. Then, is it articular? No. Means non-articular conditions, trauma, fracture, fibromyalgia, and polymyalgia rheumatica, bursitis, tendinitis, myopathy. Yes, it is articular. Is it more than 6 weeks? Yes, it is chronic. Then you go for, is it inflammatory? The period of prolonged morning stiffness, soft tissue swelling, or the systemic symptoms, ESR, CRP. Are they elevated? Yes, chronic inflammatory arthritis. No, chronic non-inflammatory arthritis. If it is chronic inflammatory, then you have now many joints involved, or only one joint. More than 3 joints, chronic inflammatory, polyarthritis, and then is involvement symmetric? No. Psoriatic arthritis, reactive arthritis, centropathy. It is symmetric, proximal interphalangeal joint, metacarpophalangeal joint, definitely rheumatoid arthritis, metacarpophalangeal joints and CP joints are involved, rheumatoid arthritis. Then yes, rheumatoid arthritis, no, unlikely to be rheumatoid because tips usually are not involved in rheumatoid, and it is not PIPR, MCPR, MTP, metatarsobpharyngeal joint, then unlikely to be rheumatoid. Consider SLE, scleroderma, and polymyositis. No, it is less than 1 to 3 joints are involved, then TB or fungal infections, psoriatic arthritis, reactive arthritis, posteoarticular joint involvement. Okay. Now, you have, this is when the chronic inflammatory arthritis is present. Suppose chronic inflammatory arthritis is not evident in the form of, there is no prolonged morning stiffness, soft tissue swelling is not there, there are no systemic symptoms, ESR and CRP are not elevated, chronic non-inflammatory arthritis, or the DIP, the distal interphalangeal joint, CNC1, carpometacarpal joint, 1 hip or knee joint involved. Yeah, it is osteoarthritis. We know that, and it is negative, unlikely to be osteoarthritis because bigger joints will be involved, knee joint and carpometacarpal joint, and then distal interphalangeal joint, hip joints are involved in osteoarthritis. Not there, osteonecrosis, Charcot's arthritis, which is a sort of neuropathic joint, and hemochromatosis deposition. And here you go, is it articular? No, it is not articular. Then you have trauma, fracture, fibromyalgia, polymyalgia rheumatica, bursitis, tendinitis, myopathy, myositis. No, it is not more than 6 weeks. It's less than 6 weeks. Very acute. Consider acute arthritis, septic arthritis, gout, pseudo-gout, reactive arthritis. Initial presentation of chronic arthritis. This algorithm is very useful, and you can use either of these algorithms. There they have broken into first level algorithm and second level algorithm. Here you have combined both into one. Nothing wrong in doing so. Okay. Now what is our case? Now it is we are here.
Hello.
Polyarthralgia with either joint effusion and inflammation.
Inflammation signs are present, sir. That is
Did you do joint
swelling
aspiration?
and
Joint aspiration
small
did you do?
joint. No, sir.
Yeah,
Distal second and DAP joints, sir, involving second and third fingers.
They are lasting more than 6 weeks, isn't it? There is inflammation, synovitis is there, history and physical suggest synovitis, that is more than 6 weeks, and then you have to consider systemic rheumatic condition, isn't it? We have to go this way. CBC, we have done, ESR is 120 and plus, rheumatoid factor negative, ANA awaited, renal function normal, uric acid normal, joint aspiration. If there is fluid, you can do joint aspiration. Now it looks to be more like a systemic rheumatic condition, probably scleroderma or dermatomyositis.